So without further ado, I want to introduce Kylie Woolcock, who's Policy Director at AHHA. Thanks, Kylie.
I'd also like to acknowledge the traditional custodians of the land on which we meet and pay my respects to elders past, present and emerging. We've heard this morning already that value-based healthcare, it's a global movement based on the research of Professor Michael Porter, who provides a framework for restructuring healthcare systems with the overarching goal of value for patients. It provides a patient-centred way to support decision-making in healthcare to address the often cited pressures on our system. We see it playing out internationally in the US, the UK, across Europe, Asia and New Zealand, and also here in Australia. The Porter definition measures value for the care of a patient's medical condition over the full cycle of care, with the health outcomes that matter to patients over the costs of delivering those outcomes. However, when people use the term value, it can mean very different things. As Sally mentioned earlier, cost minimisation, cost effectiveness, applying values, all having their differences. There's also debate about how it relates to the triple or quadruple aim, being patient outcomes, patient experience, sustainability and provider experience. And in a universal healthcare system such as ours, we also need to consider how societal value is reflected. In the UK's NHS, for example, value is considered in terms of three components using the term triple value: personalised value, being how well an actual outcome relates to the values and desired outcome of each individual; technical value, being how well the allocated resources are used to achieve valid outcomes for all the people in need within the population; and allocative value, being how well the assets are distributed to different subgroups in the population. The European Commission refers to these as value pillars, adding social value being the contribution of healthcare to social participation and connectedness. And more locally, we can look to New South Wales, who have adopted the quadruple aim in defining value-based healthcare, which for them focuses on delivering services that improve the health outcomes that matter to patients, the experience of receiving care, the provider experience and the effectiveness and efficiency of care. So in the absence of an agreed national definition here in Australia, let's take it as a rule of thumb to support good decision making. And this morning I'd like to take a whirlwind tour of where Australia as a system is at in terms of enabling value-based healthcare. It'll just be a taster, as I can't possibly reflect all of the activity. I'm going to use a global assessment done by the Economic Intelligence Unit in 2016 as a framework for looking at the activity. This identified Australia as being moderately aligned with a value-based approach to healthcare. It was a 4-point scale of very high, high, moderate and low. The assessment was across the 4 domains that are listed here. I'm also going to draw on a paper of mine that was published in June this year by the Deeble Institute for Health Policy Research that brought together the breadth of activity by diverse entities across our sector. And I'll even draw on activities that continues to occur since then. So the first domain relates to measuring outcomes and costs. As we've heard, typically healthcare is not an acute experience, rather the impacts are realised over time. So we need to be thinking about both near-term and relevant longer-term aspects of care. Process maps are important in understanding this, and this requires engaging everyone involved in the care cycle to get a shared understanding of actual processes of care, walking through the patient's journey. Outcome measures are primarily needed to accelerate learning, which in turn enables improvement. Healthcare has many relevant outcomes, each measured in different ways, and we want to capture outcomes such as survival and disease control, but also complications, the patient's reported health status, and also the patient's experience of care. Take, for example, a patient advocate I spoke with a few weeks ago. Young, educated, high health literacy, living in a large city. She had a chronic condition that required management through 5 specialists, GP and allied health. She calculated 25% of her waking hours were spent managing her condition. She acknowledged that some of this was a necessary part of self-management. However, she also calculated if she didn't have to travel and wait for consultations that didn't need to be face-to-face, she would get back 600 hours a year. That's the equivalent of 80 work days. She had no problem with the clinical outcomes she was achieving through her care. However, her experience reflected the enormous impact that being able to consult via video, phone, email and text would bring. These dimensions of healthcare that matter most to patients are increasingly being displayed in standardised frameworks. And we've heard about the International Consortium of Health Outcome Measurements is creating these metrics for medical conditions, and their sets cover more than 50% of the global disease burden currently. So this slide here reflects the standard set for stroke, and you don't need to read the detail, but see that it visually depicts the breadth of outcomes simultaneously. It provides clinicians, managers, patients, regulators and policymakers with a readily understandable snapshot. It's not about summarising outcomes into a single number where there are multiple outcome dimensions. We want to be able to see the trade-offs. Importantly, as has already been mentioned today, they're developed by international working groups of clinicians, registry leaders, outcome researchers and patient advocates, using a combination of administrative, clinical and patient-reported data. There are other international sets, and the benefits of using these metrics is that they create an opportunity to learn from high-performing clinical teams and innovators no matter where they operate. However, local context is also important, and there are many other standardised sets internationally reflecting this. In Australia, though, Dental Health Services Victoria was an active partner in planning a standard set for oral health care with IHHA and are currently using it to redesign the way public dental services are delivered. In Western Australia, there's a multi-institutional team for cancer management, and they've adapted the IHHA set to meet local conditions and enable practical implementation across public and private healthcare settings. In terms of how our system is enabling this, the global assessment reflected elements of our system that are positively aligned with value-based healthcare approach shown to the left through to poor alignment on the right. Positive alignment for health informatics infrastructure may come as a surprise. However, a positive score only required a stated effort to develop interoperable health records. Like most countries, significant effort is still needed to improve the quality of information, standardisation and linkage of data across information platforms in order to have the ability to track a patient's progress over time. The Australian Digital Health Agency is currently facilitating the national conversation about what interoperability should look like, the steps needed to achieve that goal and our development priorities. Pilots are being pursued. New South Wales Health has established HOPE, standing for Health Outcomes and Patient Experience, a system to support the routine collection, measurement and timely reporting to clinicians. They've also established LUMOS, a data linkage initiative that links GP data to a number of health system data collections, which is being spoken about in the program later today. Other state initiatives are developing. For example, Queensland Health is tendering for an off-the-shelf PREMS and PROMS solution for the whole state. And the Department of Health and Human Services in Victoria is piloting initiatives aimed at better understanding how PROMs can be collected and utilised within Victoria. There are many more examples. At a national level, the Australian Commission on Safety and Quality in Healthcare is doing work in this space. They developed the the hospital patient experience question set, which is a set of 12 questions for consistent measurement of patients' experiences in hospitals and day procedure services. It's been tested for validity and reliability, but it's yet to be determined if it is to be used for nationally consistent measurement, reporting or benchmarking. They've also provided a list of validated PROMs, both generic and condition-specific, that can be used. Looking at how costs are measured, in practice this is also not as straightforward as it may seem. The data we do have is in silos by service providers. We tend to capture fees or what is charged for services. So much that is captured may not be appropriate for the purpose of value-based healthcare, and methodologies are still developing. The space continues to evolve, and we want to be able to benchmark so we can learn. Using consistent measures is critical for enabling this, but there's a lot of work to be done. Clinical registries have been identified as an important catalyst for efforts to improve outcomes over time, and there's lots going on in this space. We have many registries in Australia, but they're established and funded in many different ways, and only a small number of national. I've just drawn your attention to 3 examples we have here. The Palliative Care Outcomes Collaboration. This registry provides feedback to individual services and benchmarks service to service at the state level and nationally. Importantly, it has been a leader in incorporating patient-reported outcome measures, or PROMs. The Prostate Cancer Outcomes Registry in Australia and New Zealand collects data twice a year. It's diagnosis and treatment data and includes patient-reported experience measures, which is important as survival rates are high, greater than 95%, but those who survive often experience a poor quality of life. The registry has been moving to benchmarking with reporting back to clinicians and at the service level. And the third one there is the Dialysis and Kidney Transplant Registry, or ANZ data, which is another interesting example. They're trialling the integration of patient-reported outcomes into their registry, with feedback to renal unit nurses and nephrologists within 2 weeks of measurement for use in patient care. With all this activity, ongoing thought is required about how we use registry data at the clinician level in patient care, because admittedly, it can risk being too much data in real time. Dashboards are increasingly being developed to support the reporting and monitoring of outcomes, but all dashboards are not equal. It's important to consider the purpose and not to underestimate the importance of design and testing. Here, for example, is a surgical dashboard for operating theatres. Its purpose, however, is to enhance strategic and operational decision-making. You can note what's being measured: attendance, utilisation, first case on time, cancellations. No doubt important metrics for efficiency, and as it turns out, this was developed with a business intelligence efficiency unit. However, it isn't a dashboard for value-based care. As an alternative, here is a dashboard on falls and fall-related harm. It defines and measures the outcomes that matter to patients and families: falls injuries, serious harm falls, recovery time in hospital. So it's important to keep in mind there's a lot of data out there, often collected for accountability to external stakeholders. Dashboards need to be relevant for the purpose. Moving on to the second domain from the global assessment, integrated and patient-focused care. And again, you can see where Australia was assessed as having positive and poor alignment. Knowing the basis for assessment is again important. Coordination of care is often cited as needing improvement here in Australia. The global assessment looked at specific areas: mental health, diabetes, HIV, maternal care and older people, with a positive result in 3 to be considered positively aligned. Keeping in mind these are global areas of interest and each country or region may have other priorities for care coordination. In Australia, we're seeing partnerships between the hospital services and the primary care networks and communities to develop support in coordinating care. An area where Australia is poorly aligned is integrated and patient-focused units. This is where the units are organised around the patient and provide the full cycle of care for a medical condition. With the conference today centred around integrated care, I'm going to leave the rest of the program to reflect on our alignment and activity in this area and move to the third domain, an outcomes-based payment approach. Disinvesting in the things that don't work is important, and it's something Australia has identified as doing well, but something we must continue to be cognisant of. As examples, we have the Choosing Wisely program, another international movement, a profession-led approach to eliminate the use of unnecessary and sometimes harmful tests, treatments and procedures. There's the current review of the Medicare benefits schedule, the list of health professional services subsidised by the Australian Government, looking at how the more than 5,700 items can be better aligned with contemporary clinical evidence and practice and improve health outcomes for patients. And there are many initiatives led by the Safety and Quality Commission to develop standards, guidelines and indicators. When it comes to disinvesting, we have to be able to step away from vested interests. We need relationships that support an honest appraisal of evidence from ongoing data capture, so we have the courage to invest and disinvest according to the outcomes. Another important enabler is bundled payments, where we scored mid-range on this measure, requiring having national or regional initiatives to develop a bundled payment system. And one example of this is from Australia's Independent Hospital Pricing Authority, a national body that provides advice in relation to funding for public hospitals. In 2015, it started investigating bundled pricing approaches for public hospital services, with maternity care the first model to be developed. Significant barriers to implementing the model were identified that precluded implementation at the time, and this was without even including care provided outside the public hospital sector. However, research into innovative funding models continues to be part of their work program. Another example of trialling bundled payments in Australia is the National Healthcare Homes program, where patients register with a general practice to receive care for their chronic and complex health conditions. The GP receives a monthly bundled payment based on the level of complexity of the patient according to 3 tiers, and we look forward to the first evaluation report that's expected sometime after this month. This brings us to the final domain, the enabling context, policy and institutions. Universal health coverage in Australia provides an important enabler for value-based healthcare. However, there are concerns about this being undermined. When we talk of stakeholder support, it's important to recognise that clinician and organisational leadership is a critical success factor. Top-down approaches will not be enough. We need to engage our workforce and use to the top of their scopes of practice. And in health technology assessment, we've identified as world leaders. The system, though, still faces challenges, like how we incorporate real-world evidence and post-marketing surveillance into approval decisions. We're going to be faced with continue to be faced with high-cost technology, such as the growth in whole genome sequencing, and it's going to come at a significant cost. With universal health coverage, how do we sustainably ensure equitable access? Overall, though, what you can see is that there is a lot happening in this space by many entities. Our lack of any explicit or formal strategy may undermine success. It's not just national consistency in how we measure that it's important. For those not familiar with Australia's federated healthcare system, this picture shows just the funding flows in our healthcare arrangements from the federal government, states and territories and private funding. It's just to show the complexity, nothing else. But with divided responsibilities, a national strategy is important. There is some hope. Since the global assessment was done, we've seen the COAG heads of agreement between our Commonwealth and states and territories, signed by 7 out of our 8 states and territories. The clause includes phrases that reflect activity to enable value-based healthcare, reforms to improve patient outcomes, joint planning and funding at a local level, paying for value and outcomes. While it's yet to be seen what this clause will actually mean in practice, the Commonwealth and states and territories are working on implementation plans. So where to from here? Taking a recent quote from the chair of the Productivity Commission, Michael Brennan, he said that any policy reforms to healthcare has to start with the realistic premise that there is no big bang reform that will get us where we want to go in a short period. Health reform is an ongoing process, but this time it's often government and the various parts of a publicly owned, funded and regulated system that have to take those thousands of decentralised steps. You can see that there are a lot of elements that need to come together. In June this year, the Australian Healthcare and Hospital Association established the Centre for Value-Based Healthcare to provide a nexus for this activity. I invite you to visit our website, which shares many of the Australian experiences I've spoken of today, as well as a range of other resources. Thank you.